Okay, welcome everybody to the live portion of our session, and thank you to the panelists for really interesting and thought-provoking presentations. So we have some questions here that I'd like to direct to each of you. So the first one is for Brian. What was the rationale for going back to the independent double check? Did they want more data before making the actual change?
Great question. Yeah, I think it's a nervousness by our organization that even though the Institute for Safe Medicine has said that it's up to local organizations, it seems like an apparent standard for a lot of hospitals to do independent double checks. So our organization was quite nervous to really be on the forefront of this, and so that's why I think we need more data and we need to study it more. Hopefully we can get everybody to move forward. But yeah, it's really funny. My nurses are really strongly trying to say, help me, Brian, help save it so we don't do this because the data doesn't support going back.
Great. Okay.
I already got a text from my coordinator asking me if we could duplicate your study, Brian. So.
Yeah, well, that's what they really want. They said, get us more data, and they're willing to move forward. So really what we need is a couple more hospitals for 6 months, and we can knock this out and really, I think, really change nursing practice.
Something to look forward to, definitely. I've been doing it many years, so we'll see where we go. Thank you, Brian. Okay, the next question is for Dr. Carroll. The comment is super interesting stuff. Though many of these patients escaped PICU care, is there analogous data on the admissions to the floor or ED visits for children? That piece is helpful in making some of the conclusions made.
Yeah, that's absolutely true. There's not great data for the floor that I'm aware of. I think there is data for emergency departments, but I can't speak to it. But that's an excellent point.
And just to follow up, one of the participants is just sort of commenting about the disappearance of asthma and pneumonia. And do you think they can be attributed to, first of all, parents not taking kids to the ER hospital for fear of COVID? And if children that were admitted with a positive COVID-19 test were assigned a COVID-related diagnosis and pneumonia was present, but related to COVID?
Yeah, so that's a great question about were there children who were just missed? This phenotype is the most severe phenotype. So I don't think any these are not possibly kids who could have been treated at home. So by any stretch, they would have gotten into trouble. I did reach out to some local Department of Public Health to see for example, did they have an increase in mortality in children in this age group, and got some anecdotal data that they had not, but they were way too busy to help me out with granular data.
Sure. We still have a lot to pour over as the surges slow down and give us time. Okay, this next one is for Dr. Forbes. Really fantastic talk. Think there is any way to leverage VPS data to look at implicit bias?
Oh boy, boy, that's a great question. Off the top of my head, I would probably say not right away. I think implicit bias is also kind of ethereal, right? And you would need more than VPS data to begin to look at that. But again, I think the data are what they are. We don't always like what we see, but I think VPS is a great place to start. And I think trying to understand how implicit bias and the social determinants drive Pete's critical care is certainly, I think, something we can do through VPS.
Yeah, and I'll just comment as a site coordinator that I know in the last year, in almost every report that we've run, we've included race as one of the elements to look at, and not so much the payer. I'm at Kaiser, so I will add that. But it really helps us double check what we think we know, and let us see the real data. Are we doing what we think we're doing? So I really appreciated that aspect of your presentation. And now here's a question for Dr. Shein. How many FTEs are entering patient data in the VPS database in order for you to stay so current and up to date to run your reports?
Oh, great
I'm
question.
curious of that too.
Yeah, great question. And thank you again for the invitation and for all the audience for watching the talks. So we have 2 people that are roughly 1.5 FTEs. And I'll admit they do a fantastic job. Not admit, I'm very proud of the fantastic job they do keeping up with things. But we do it in sort of a 2-tiered approach. So they put in some preliminary data for every patient every day, like for the new admissions, and that enables us to get most of the data that we need for M&M and for the other purposes. And then only at discharge, they go back and kind of do everything else. So essentially, the M&M list has every patient that's gotten admitted, but doesn't have all of their data, but it's enough to at least capture the since it's from admission, the bounce backs and the early intubations.
Okay, got it. I was curious as well because I know I'm not that up to date. Okay, here is a question. I'm not sure who this is for. I think, okay, if human factors play such an important role in patient safety. So I think this is for Matt, actually, who's not on our call. This is, should we be exploring the impact of physician workload, going into the idea of shorter shifts, less frequent calls, and would that impact better patient outcome? So I will say to Ron Sanders, for all of our panelists, you can email them with your questions to continue the dialogue. I wanted to comment also, Dr. Shein, on your concept of keeping positive outcomes in front of staff. I think that is really huge, and I see nods everywhere. Yeah, because you're right. We all tend to focus on the one that didn't go the way we wanted, and for that one, there's 10 that did. So really liked that idea. Panelists, did you have any questions for each other after hearing the other talks? Are they on mute?
Looks like everyone else got muted, but no questions from my end, but just compliments for some fantastic talks, everyone.
Yeah, no, and I wanted to comment on your human factors analysis, Maria, that you brought up for Matt. His talk, I only got to see half of it because I'm in the CI. But I got to say that I think that revolutionized doing some of the human factors analysis is really Leah Kowinski is our human factors engineer for Helen DeVos, and that's really kind of revolutionized how we think about things, and kind of like the stuff I was mentioning, like social loafing. I was like, I've never heard of these terms before. It's really great to have someone like that to help you look at and analyze some of these things. So I think that really getting to kind of, I know Tom's talked about the future. I think using some of those engineering principles and human factors is really going to revolutionize medicine, and it's kind of the next step, I think, in how we get to that better quality of our patients. It's going to play a big factor.
Great.
And I'd like to echo the compliments to Steve about those plaques. That's a really spectacular idea. So great job with that.
I got a great company that makes them if you're looking to get somewhere.
Oh, very good. And let me see. I wanted to ask Dr. Carroll a little bit about we are in our sites. I do 3 sites, and we are also interested in looking at if there's an increase in suicides or not suicides, attempts during the COVID time period. And what I know you were looking at that and seeing if you found some differences. Any other thoughts on that, where that's headed?
Yeah, we're currently analyzing that data. I think everyone on this, all 200 and some odd people on this call have seen an increase in the psych admissions to their emergency departments, and it'd be interesting to see how that translated to the pediatric ICU as well. we currently have the data from the VPS, and we're analyzing that. So I can't give you any data yet, but it'll be a really interesting part of the data analysis, I think.
Yeah,
I can actually speak on a little bit too.
Oh, go ahead.
I'm one of Chris's
because
co-authors.
Steve has the data and is currently.
I was actually doing the preliminary version of that analysis actually this morning, and I obviously don't want to speak to it because it's preliminary, but I'll just tell you that it's surprising.
Oh,
okay, all right.
A teaser.
More to come.
Okay, we look forward to it. Well, I want to thank all of you for participating. This has been great, and really hearing lots of different views on how to use VPS data in our local sites, and you've given us a lot to think about other ways to use it. So thank you so much for sharing today, and thank you for your engagement. And now I'm going to turn it back over to Dr. Tom Rice to close us out. And again, for participants, please feel free to reach out to any of the panelists with further questions as you think more about their presentations.